Well, I have a good number of questions, so let's ask Dr. Goldstein. Question about the rituximab. I've been using a lot in not just PUK scleritis, but also mucous membrane pemphigoid. So the question is that how do you dose them, and do you taper the medication?
So that's a great question. I didn't have a ton of time to go over it. There's two basic ways to dose it. Rheumatologists, and what I tend to do is it's 1,000 milligrams times 1, and then again 14 days later, and then we do that every 3 to 6 months. But the oncology dosing is 375 milligrams per meter squared. I have no idea what meter squared is. I think a 6-foot-tall, 70-pound person is about 2 meters squared, but I live in the Midwest, so nobody is 70 kilograms. So that dosing is 375 milligrams per meter squared every week times 4, and then you space it out. But I just do 1,000 milligrams twice, and then every 3 to 6 months.
Great, thank you. For Dr. Fulfelder, a lot of questions regarding how to use the tacrolimus topically. You know that there's nothing available for ophthalmic only. There's only a skin formulation. So how do you use it? Do you specially compound it? And do you put an eyelid in the eye? How long do you treat the patients for?
Yeah. Well, first of all, this is an off-label indication, just so everybody knows. But I use the dermatologic ointment. It comes as either 0.3% or 0.1%. Actually, the 0.1% works fine also, but I usually start with a 0.03%. For 1 or 2 nights, I'll have them rub it all over their eyelashes and their lid margin. And if they don't get a lot of burning, then I just tell them to pull down the lower lid and to instill it in there, usually at night and sometimes twice a day. And I have some patients that have used it for months or even years with severe atopic disease. So it seems to work very well. Fortunately, it's generic now, so it's usually fairly reasonable.
Great, thank you. For Natalie and Victor, in terms of the topical steroids, do you think there's a role for those for those two, PUK and scleritis, in addition to the systemic immunosuppression?
For scleritis, no. I think it's a systemic disease. You need some form of anti-inflammatory therapy. If you think of the pathophysiology, it's the vasculitis, and you have the deep and superficial plexus that are being epicleral plexus. Those are the one affected. So you start with a step-ladder approach. I mean, if you have a diffuse scleritis, you can start with a non-steroidal and move forward. But in fact, patients can get very, very dependent on topical steroids. I know there's a school of thought that maybe FML can be metabolized better by the sclera for the treatment of scleritis, but I usually stay away from topical steroids. PUK is different, though.
So it depends on what is the condition. We have a number of things in the periphery of cornea, such as marginal keratitis. For those kind of things, steroids are indicated. But then if there is anything like scleritis, then I'm super careful not to watch out before starting anything.
Great. Yes, it's very important to figure that infectious was non-infectious. For Dr. Shan, and it's really difficult to, this umbrella of everything there. So what's your approach, when you see a patient with interstitial keratitis? How do you start?
So, it really is. It's just back to the basics. A good exam, and really it's the history, talking to the patient about when the symptoms started, how the symptoms started, and then doing some basic testing, basic blood testing is reasonable. At least a CBC, SED rate, and CRP, just to see if there's an inflammatory state beyond. If there's a clear indication otherwise that it is just an eye condition, potentially just starting on steroids, but I really do shy away from starting on steroids without having a sense of what's going on first.
Great.
I'll put in a vote for testing for syphilis and TB first.
Yes, that is a must. So for Dave, I love the case. Now, retrospectively, I think about those recurrent conjunctivitis, whether they have those syndromes, because I never thought about disease entity.
Yeah, I think about it every time I pre-op a patient because, they have this really deep fornix, and I think we're going to actually see it more with the prostaglandin analog-induced orbitopathy. So this is a condition that's going to be on the rise. We all need to look out for it. And honestly, I think it's a biofilm disease. It's just all this, the bacteria are kind of, hiding in the biofilm. They're just kind of, and our antibiotics that are typically so effective right away really have trouble penetrating through and getting, having eradication of the organism. So really you need to just get in there, and it's not just your classic conjunctivitis. You really need to do that mechanical sweeping and really the lavage and the squirting. You just have to get in there and get your hands dirty.
Great, and also important point from your case is that initially the culture was sensitive to everything. Then the second culture is completely like another animal. So what was your recommendation? Like, do you culture every time the patient recurrence?
Yes, we culture all the time because, these are chronic infections, and if we hadn't cultured, she would have gone weeks more. It's like just, throwing darts in the dark if you really don't know what you're treating. So in this case, this elderly patient, her rheumatologist had kept her off of her systemic therapy because of her red eye. So, rightly or wrongly. So, we wanted to clear this up as soon as possible. So really, cultures, I think, are extremely effective. She also had an ulcer on her toe at the same time, which is another reason that she was off therapy. So, this patient was sick. And so I think, cultures don't take that long. I think they're very, very helpful.
Another point is that it could be a combined mechanism, right? These patients might not have the right immune system to handle the truth. So now you have a biofilm, a bananotomy, and a bad immune system that cannot get rid of the normal organisms, and you get a vicious cycle.
Right.
Very interesting.
Yes, it's a great case. Thank you so much.